Yeah, I apologize with the patients. Yeah, there's a very good clarification here. You know, the patient is not failing the treatment; it's the drug that fails the patient and the treatment. That's correct. You know, honestly, the drugs are not helping our patients. It's not the patient's fault. You know, sometimes the way that we say things is not correct. There's another question that what happens when the patient has EGFR and ROS at the same time? That's not very common, but we already have seen these things before, you know, especially with ALK. There is a publication from China with thousands of patients that were tested, and the EGFR plus ALK concomitant is a very small group. And this small group got treatment with both TKIs at the same time. So that's the only experience that we have. And some of us have had sequential. I have a patient that had EGFR, and then, I don't know, 3 years later, I discovered the ALK, and I guess maybe I missed at the beginning because technology improved, and then I catch the ALK later. So the patient benefits from the EGFR first and the ALK later. What do you think, Jessica? Will you give if you have a ROS and EGFR, you will give both treatments, or you will try to see which one is the driver?
I think the first key step here is to personally communicate with the pathologist, the molecular pathologist, and really understand what is the fraction of tumor that has the EGFR mutation versus ROS1 fusion. Is it a true anticipated to be functional ROS1 fusion? That kind of one-on-one discussion is critical in really having confidence in thinking that the tumor has both a functional EGFR mutation and a ROS1 fusion that is driving that tumor. So that is the first step. Once there is confidence in that, then if we truly think both proteins are important in the cancer survival, we would make every effort to try a combination approach, even though there's no combination regimen that is approved, kind of on a single patient compassionate use protocol type therapy, trying a combination approach. We have tried a combination of osimertinib and crizotinib, more for patients, for example, with EGFR mutant lung cancer who have a MET amplification as an acquired resistant mechanism in the tumor, and the combination was able to be tolerated. There, the key point is monitoring for side effects and deciding on the right dosing to try initially. I did want to take a minute to go back to the prior point, which Dr. Raez also discussed. I am so happy that this came up, and I could spend 15 minutes discussing this point because I feel very strongly about this. It is not the patient that fails the therapy. It is the drug that fails the patient. It is not the patient who progresses on therapy. It is the tumor that progresses. It's not that the patient is ALK positive, it's the tumor that is ALK positive. And it's not that patients are complaining of side effects, it's that they are reporting side effects to the oncologist. And I think these are such important points that we need to continue to discuss on and on. And whenever you see that that mistake or error made, please speak up and let us know so that we can be more cognizant of our language, because the words do matter.